Okay, and then we're gonna grab our intubation equipment. We're gonna add an extra viral filter for the end of our endotracheal tube, and we are gonna glide scope this patient. So come over here and we'll set this up as well quickly. We'll have place the monitors on the patient, hook up the IV, and one of our colleagues, one of the two people, will begin the pre-oxygenation process. This right here is our viral filter. This viral filter, actually, right here we have one set of viral filters. We have received word that these work for COVID, and so therefore this filter right here is protecting our CO2 line. Okay, so we're putting it here, and we're also, whenever we disconnect or reconnect our circuit, we keep that filter on there. All right, so somebody's gonna start pre-oxygenating this patient. I'm keeping the plastic on in order to try to not waste supplies. So we're gonna start pre-oxygenating the patient after our monitors are on. Somebody else will go ahead and give your propofol and your succinylcholine, and you will go ahead and do a glide scope intubation that's deep and well paralyzed, with your face away, if possible, from the airway of the patient. Of course, just like anytime you do a general anesthetic for a cesarean delivery, you're also waiting until OB is ready. After you've intubated the patient, you've done your deep induction. You've intubated your patient. You're going to remove this here and make sure that you're hooking up with your viral filter onto the end of your endotracheal tube. You're going to lift and make sure that before you start insufflating, you have watched your cuff insufflate under your glide scope. So your cuff goes up under your glide scope, then you hook up here, and you go ahead and start ventilating the patient. All right, so when I do a general anesthetic, people do this differently. I usually start with 100% oxygen and high gas until the baby's out, and then I go down on my oxygen and start going up on nitrous oxide in order to prevent significant uterine relaxation from high volatile. So I usually start 100% oxygen with high volatile until baby's out, and then once baby's out, I drop my volatile, go higher on the nitrous, and that's just fine with these patients. All right, the baby will be born in our setting. The baby will go next door into the neonatal resuscitation room because the baby is considered a patient under investigation at this point. Also the neonatal resuscitation room will stay in the modified droplet plus aerosol producing, so the N95s or PAPRs. When it's time to extubate, it's important to try to avoid coughing. There's different techniques that are on our website, including various lidocaine or deep extubation. I don't recommend a deep extubation in a pregnant woman. Pregnant women can wake up hard. Lidocaine is not an unreasonable thought. If I have a patient that's requiring significant oxygen requirements, my thoughts are to keep them intubated and go up to the intensive care unit immediately after. The reason in extubate up there, the reason is because there's significant fluid shifts that can happen during a cesarean delivery, and it would be nice to get those settled out before. If you have trouble ventilating your patient, don't forget about that these patients are at risk of potentially going to ARDS, so doing lung protective ventilation measures, putting some PEEP on, and having low tidal volume, rapid heart rate ventilation. Of course, you want your end tidal CO2 in a pregnant woman around 30. It is okay if you did paralyze with rocuronium and you're planning on extubate to reverse with Sugammadex. And I can't think of anything else to tell you right now. I'm sorry that this is so silly, but I just wanted to give you guys something to show you how I'm walking through this process. Now, we will probably change this a number of times between now and when we really understand this process, and I sure appreciate everything. Oh, Peter wants me to talk about the neonatal resuscitation room. So in our practice, the baby will be born, will come through, go right into here, and this door will be shut. If our patient's under regional anesthesia, that saves everybody in here from having to be in N95s and allows us to conserve resources. If, however, in your obstetric unit, if you're using regional anesthesia, your baby's born to a COVID positive mom and comes over here to start the neonatal resuscitation process, there is a chance this baby could be suctioned, right? There is a chance this baby could be intubated because those are aerosol generating procedures. It is reasonable if you're resuscitating your baby in the room, in the delivery room, it is reasonable for you to have N95s on for your entire team that's going to be in this room from the beginning of the case. Other questions, Peter? Anything else you can think of?
Could we go in there?
Yes, we sure can. This is the neonatal resuscitation room. Here, this room will be where our babies are. We want to make sure this door stays shut, and this room will be separate. So if we're doing regional anesthesia in there, we may not be in N95s, whereas the baby will be brought into here, and this room will be in N95s. So the things right now that are important, I think, to remember: do regional if you can. See if you can avoid a general. Talk to your obstetricians about that. We've talked to ours, but we know no matter what in OB, we can't prevent it 100% of the time. Focus on your PPE as you put it on, and also focus on your PPE as you take it off. When your case is done, you can decide whether to go to the ICU or whether to go back to the labor room, depending upon what your practice or how stable the patient is. If you're going to extubate in here, at the time of extubation, that's considered an aerosol generating procedure. We have figured out what our turnover time's here, and it's 30 minutes for our labor rooms. So as we leave this room, we're going to write on this thing, and we're going to revise this sign a little bit, but it's essentially going to say do not enter until a particular time, because that everybody in this room after extubation that walks in here needs to be an N95 until the room has turned over to clear 99.9% of the aerosols that may have been produced. My understanding is our rooms in our labor and delivery are not negative pressure rooms, they're positive pressure rooms. It doesn't matter for the people in the room, it matters for the people outside the room. So the people that come and are delivering anything to you outside of these doors, I recommend that they remain in surgical masks. These doors remain shut. We'll leave things on this table. We'll open our door, reach out and grab them, and shut our door again. But really, somebody shouldn't be standing right outside this room without any form of a mask on. Use common sense. Yes, as we leave. All right, so a couple concepts. 1, don't walk through the hallways in dirty PPE. 2, make sure you stay in your PPE when you're with that patient. So what does that mean? That means you've now extubated your patient, they've moved over to the cart, you're ready to go. You're in the PPE that you wore for the entire C-section. You're going, and yours right now is N95. You need somebody out here to help you transfer, because you're going to come out, and somebody out here who does not necessarily need to be in N95s, they just need to be in modified droplet, so the surgical mask, is going to receive that patient and transfer them in clean PPE through the hallway, while you carefully go through the process of taking your PPE off. We feel it's important that while you're removing your PPE, you also don't have patient care responsibilities. So, as far as the doffing of PPE, you will go through your process in which you move, and it is not unreasonable to have these as well. Be ready. So for your doffing PPE, you're going to come outside the room. You're going to take off your gloves, and you're going to perform your hand hygiene. You're going to remove your eye protection, your face shield, and your protective eyewear, and you're going to perform hand hygiene. You're going to remove your glove, and you're going to perform hand hygiene. And then finally, at the very end, you're going to close. You're going to come outside. You're going to do all that out in here. You're going to come outside the room. You're going to close the patient door. You're going to perform hand hygiene, and you're going to remove your respirator. If you were in a room with a patient with positive was COVID positive, you need to throw that respirator away. So your N95 needs to get thrown away. Your PAPR needs to be sent for reprocessing. When you're complete with your Dolphin, you've removed your N95, you're gonna perform hand hygiene again. Then you can call back into the patient's room where your colleague took them to give a verbal sign out to the nurse that may be in that room. And that's all. Good luck. Thanks, guys.